Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network. And thank you so much for being here with us today, February 26, 2019, for our Medical and Surgical Oncology lecture. A few preliminaries before we get started. We will start promptly on the hour. We talked about the sound checks. This is some new information, basically just to fill you in while we're waiting to get started. And so I'm going to go ahead and move straight to our Poll Everywhere slide. Let you know that this is an interactive presentation. We have two different ways that you can participate. One is with Poll Everywhere. One is through a web browser, so you can go to any web browser on a smartphone, on a tablet, on a PC, laptop, etc., and you just go to pollev.com, pollev.com/UNCCN. You'll see the questions and be prompted for answers as we go along, and then at the end you'll have an opportunity to share your own questions. If you would prefer to do this through texting, you can do that as well. Any phone with texting capabilities. In the to field, type in the numbers 22333. In the message field, type in UNCCN. Submit that. You'll get a message back that says joined, and then as you go along, just put the letters that correspond to the answers for the questions, and then you can text in your own questions at the end. So one of those ways, we hope that all of you will interact with our participants during the presentation. The first question that we'll be asking is about blank of the blood cancers that occur, and we're looking for a fraction here, about what fraction of the blood cancers that occur each year are lymphomas or cancers of the lymphatic system. If you believe that answer is 1/5, you'd put A, 1/4 B, 1/3 C, or 1/2 D. All right, and these are all anonymous. This is just one that's an icebreaker, just to allow you to go ahead and start using Poll Everywhere before the presentation begins, or as the presentation goes along. All right, so we have two guests here today. We have Dr. Stefan Moll and Dr. Ann Beaven. Dr. Moll, thank you for being here with us. Welcome.
Thank you for having me here.
Dr. Beaven, thank you so much for being here today. So let's see a little bit about each of you. Let's see, Dr. Moll, a faculty member at the University of North Carolina Department of Medicine in the Division of Hematology Oncology for the last 18 years.
That's correct.
That is terrific. Clinical interest in coagulation and classical hematology with a particular focus on thrombosis and anticoagulation. Research interests include clinical trials on new anticoagulants and better use of established anticoagulants. And stop me if I've got anything wrong along the way here. And with special interest in clinical medical education of patients, the public, and healthcare professionals, and co-founder of the Blood Clot Education program Clot Connect at www.clotconnect.org. Does that all sound about right?
That sounds correct.
Perfect. And what's something that I didn't list here that we should know about you?
Well, number one, I'm not a malignant hematologist,
All
but
right.
a benign hematologist.
All right.
Secondly, I'm a father of 4 teenage girls.
All right.
And thirdly, my main hobby is wood turning.
Oh, very good. So work with a lathe. Okay, great. And Dr. Beaven, Director of, let me progress the slide here, Director of Lymphoma, of the Lymphoma Program at UNC, and 10 years of experience as a clinician and clinical researcher in lymphoma, and caring for patients with all types of Hodgkin and non-Hodgkin lymphoma, including indolent and aggressive variants. And special interest in T-cell NHL, cutaneous skin lymphomas such as mycosis fungoides, and along with dermatology, running a multidisciplinary clinic for patients with skin lymphoma, and heavily involved with the development of UNC clinical trials of immunotherapy with CAR T cells in patients with relapsed refractory Hodgkin and non-Hodgkin lymphoma.
Yes.
Okay, great. So we've got that right. And what about for you? Something we should know that wasn't on the list there.
I only do malignant hematology, mostly lymphoma, even though I got great training from Stefan when I did residency and fellowship here.
All right, so you're a powerful pairing of knowledge here. This is great.
Don't ask us about lung cancer.
Okay. So looking at our poll, and if you haven't had an opportunity to do this yet for our audience, please go ahead and take a few more seconds. We're sort of leaning towards 1/3. What do we have as the actual answer here?
Well, If I had just ballparked, I would have thought 1/3
You would have
also.
thought 1/3.
But the actual answer is about 1/2. And this is, of course, taken into account myelodysplasia and other sort of malignant hematology cancers. So it's about half of cases.
Great. Well, thank you so much. And I do have disclosures. This activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. Dr. Thomas Shea consults for Spectrum Pharma and receives research support from Millennium, Otsuka, GSK, BMS, Novartis, and Seattle Genetics. Dr. James Coghill, MD, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Thanks to the speakers, Dr. Moll and Dr. Beaven, have no conflict of interest relevant to this presentation. All right, and with that in mind, key 2018 and 2019 developments in lymphoma and thrombosis anticoagulation. And Dr. Beaven, you're up first.
Okay.
All right, there you go.
So most of what I'm talking about is some of the exciting abstracts that were presented at ASH, the American Society of Hematology meeting this year. And so it was actually a very exciting year because often I'll go to these ASH conferences and find sort of the 5th or 6th year that they're reporting the same data, or here's just a bunch of phase 1 or preclinical studies. But this year there were actually 3 randomized controlled trials. I'm not sure all of them are going to be practice changing, but still some really interesting results. So one of these has to do with frontline treatment of T-cell lymphomas. One of these is looking at how should we handle young patients with low risk limited stage diffuse large B-cell lymphoma, and then another one is looking at what should we do with this higher risk diffuse large B-cell lymphoma patients, these non-germinal center B-cell. And then I'm also going to just touch on a phase 1 or 2 trial that was done, not because this is changing practice now, but it speaks just a lot for where we're going and thinking about how we're going to be treating Hodgkin's lymphoma in coming years. So this first trial, the Echelon 2 trial, was looking at brentuximab vedotin plus CHIP in CD30 positive peripheral T-cell lymphomas. And the background on this is peripheral T-cell lymphoma is actually a rare non-Hodgkin's lymphoma. Depending on the data you look at, it's probably 8 to 15% of non-Hodgkin's lymphomas are T-cell lymphomas, which is a good thing because these patients typically do not do nearly as well as the more frequent diffuse large B-cell lymphoma or follicular lymphoma. The one exception for those is the ALK-positive anaplastic large cell lymphoma, which those patients do fairly well. But the ALK-negative anaplastic large cell lymphoma and all of the many other subtypes of T-cell lymphoma really have very generally short survival and low chance of cure. So there's a high unmet need for looking for new therapies and how can we improve outcomes further. So this study is looking at brentuximab vedotin. Brentuximab vedotin is an antibody drug conjugate and it targets CD30. And this is important because all of anaplastic large cell lymphoma and a smaller percentage of the other T-cell lymphomas will have CD30 expression. And so they potentially could be targeted by this therapy. So brentuximab vedotin is not a new drug. It actually has many FDA approvals. So it's FDA approved for relapsed refractory Hodgkin's lymphoma. It's recently been FDA approved up front for stage 3 or 4 Hodgkin's lymphoma in combination with AVD. It's also FDA approved for maintenance after autologous stem cell transplant for patients who have high-risk Hodgkin's lymphoma. So those patients who might have had an early relapse and then gone to transplant could get this for some time afterwards. For the T-cell lymphomas, it's FDA approved for relapsed or refractory systemic anaplastic large cell lymphoma, as well as for those cutaneous T-cell lymphomas that are CD30 positive. And the one that's highlighted at the bottom is the newest FDA indication, and that is as a result of this study. So it's now FDA approved for previously untreated systemic anaplastic large cell lymphoma and other CD30 expressing T-cell lymphomas in combination with cyclophosphamide, doxorubicin, and prednisone as upfront therapy. So this is really exciting, a trial presenting that actually has changed our management for some patients. So the Echelon 2 study is looking at adult patients who had at least 10% expression of CD30 on their cells. And it's interesting that they chose 10% because there's a lot of data showing that the amount of expression on the cells, the amount of CD30 expression does not correlate linearly with response to brentuximab vedotin. We've seen this in Hodgkin's lymphoma as well as T-cell lymphomas, where you could have a patient who has very low expression who might have a complete response and somebody who has 100% expression who has no response to brentuximab vedotin. Part of this is because the CD30 staining really isn't a great test, but there's a lot of talk about is just one cell that has CD30 enough to give this drug or not. But in this study, it had to be 10% or higher. And because the ALK-positive anaplastic large cell lymphoma patients are the ones who do the best, in order to be enrolled in the study, they had to have a little bit higher risk disease. They had to have an IPI, so a higher prognostic score of 2 or higher. In contrast, any other T-cell lymphoma or even the ALK-negative anaplastic large cell lymphoma could go on whether they had low-risk IPI or not, because these are inherently high-risk diseases just from being T-cell lymphoma. So there were about 500 patients who were put on the study, and if they were randomized to standard CHOP or brentuximab vedotin plus CHIP. So what the CHIP is, it's basically CHOP with the removal of vincristine. And this was done because vincristine and brentuximab have overlapping toxicities of neuropathy. So the baseline characteristics of the two arms were very similar and quite similar to what I would expect to see with T-cell lymphoma patients. So median age of around 58, which is pretty standard. More patients had higher risk IPI. The majority of patients, about 80%, had stage 3 or 4 disease. The study made an effort to enroll more patients with anaplastic large cell lymphoma. So the majority of patients did have this diagnosis, but many of them were ALK negative. So the higher risk anaplastic large cell lymphoma. And then we have a smattering of angioimmunoblastic T-cell lymphoma, peripheral T-cell lymphoma not otherwise specified, and some other less common types. And what they found was that adding the brentuximab vedotin significantly improved progression-free survival. So you can see here a median progression-free survival for the brentuximab vedotin arm of 48 months versus only 20 months for the CHOP. So that's a pretty big change, really a doubling of the median progression-free survival. And we can see that difference continues even with longer-term follow-up. For overall survival, there was also a significant improvement of overall survival with the brentuximab vedotin arm. So after median follow-up of 42 months, you can see that there have been 23% of patients were deceased in the brentuximab vedotin arm versus 30% of patients in the CHOP. So it really was a significant reduction. So when they designed the study, they did set up some pre-specified sort of subset analyses, kind of looking at, are these different T-cell lymphoma types one more likely to respond than another? Are higher risk patients more likely to respond to the brentuximab? And what they found, looking at progression-free survival, as well as the other things, is that there were some differences. Most notable when we look down here at the disease subtypes, that the highest benefit was really in these patients who had the low-risk anaplastic large cell lymphoma that was ALK positive. So if you remember, for interpreting these kinds of graphs, everything that's over to the left is definitely in favor of the brentuximab vedotin. Things that are over to the right would be in favor of CHOP, and then whatever's crossing the midline are things that are sort of not statistically significant. So the ALK positive anaplastic large cell lymphoma is very far over to the left. The other types, it's not as clear. They sort of trend towards the left, but cross that midline a little bit. The other place that we saw some differences seems to be more beneficial in the patients with a higher risk disease. So if you look at the disease stage, patients with stage 3 or 4 disease are more likely to have a benefit from the brentuximab. They did the same thing with overall survival benefit. Here you're seeing much bigger confidence intervals because the number of patients that died obviously was smaller. But still, almost everything seems to be leaning in the favor of brentuximab vedotin, although they are not all statistically significant. Adverse event-wise, they're fairly similar between the brentuximab vedotin and the CHOP arm. The biggest difference to know about is the change in diarrhea. And if you look at the diarrhea, you say, oh, most of it's light blue, which is a grade 1 or 2 diarrhea. Maybe that's not such a big deal. But actually, grade 1 or 2 diarrhea is pretty bad. Grade 2 diarrhea, I think, is something like 4 to 6 bowel movements over your baseline, which could be quite a few bowel movements for one day. So even the grade 1 or 2, which is about 30% of patients, plus the grade 3 or 4, this is significant diarrhea, and I have run into this problem with some of my patients that I've treated with this regimen. So it's really important to give your patients some discussion about that when they're starting therapy, that they might be having diarrhea, talk about Imodium and sort of other interventions that they could use. As far as infection, the study just allowed the investigator to choose whether to use growth factor or not. The FDA recommendation is that you do use growth factor with this regimen. And as you can see, there was certainly a decrease in neutropenia when patients used growth factor. So the green is with the growth factor, the blue and the pink are without growth factor. But there wasn't a huge change in the rate of febrile neutropenia, even with the addition of the growth factor. But at this point, we do use the G-CSF or Neulasta more frequently. So the conclusions for this are that ECHELON-2 is the first prospective trial in peripheral T-cell lymphoma to actually directly compare two trials and ever show a benefit of one versus the other. So we're definitely seeing a progression-free survival and overall survival benefit with the addition of brentuximab vedotin. So this is really exciting. The brentuximab vedotin plus the CHIP just have a clinically meaningful improvement in progression-free survival as well as overall survival with a 29% risk in progression events and 34% risk in risk of death. And generally, other than the diarrhea, fairly similar as far as toxicity. So this is an FDA-approved indication for this. I would say that in clinical practice, most people are probably using this with the anaplastic large cell lymphoma, particularly the ALK negative. I hear a little bit more discussion about what to do with other CD30 positive T-cell lymphomas. Thus far, I have been including those patients in the brentuximab vedotin treatment. Part of that discussion comes from the fact that often outside of a clinical trial, we're treating patients with a CHOP plus etoposide regimen. So there's some talk of should CHOP be really the comparator. But the data showing that CHOP plus etoposide is really better than CHOP is pretty limited. So I think that this data really supports using brentuximab vedotin in the relevant patients. So the second trial that was looked at is what's called the FLYER trial. So now we're moving from T-cell lymphoma over to diffuse large B-cell lymphoma. And this is a trial looking at low-risk patients. And so young patients, 18 to 60 years old, with an age-adjusted IPI of 0. So what an age-adjusted IPI of 0 means that they have stage 1 or 2 disease, good performance status, and they have a normal LDH and no bulky disease. So they were randomized either to 6 cycles of R-CHOP or 4 cycles of R-CHOP plus 2 additional cycles of just rituximab alone. Even though these patients had limited stage disease, radiation was not a planned part of this therapy. It was a non-inferiority trial. The background for this trial is because, if you remember from way back when, the MINT trial, which is one of the studies that looked at CHOP plus or minus rituximab in the 18 to 60-year-old patients, they looked at their subgroup analysis and found that the patients enrolled in the current study in the FLYER trial, so those who had an IPI of 0 and non-bulky disease, did really well. And you can see there the red line. So those patients who had no risk had very good survival and very good chance of cure. And I thought, well, maybe these patients do so well, we don't really need to give them 6 cycles of CHOP. Maybe we can give them a little less chemotherapy. And so that was what was done in this study. And as you can see, there was absolutely no difference in outcomes for the 4 cycles of R-CHOP plus 2 cycles of rituximab versus the 6 cycles of R-CHOP, with 3-year progression-free survival in the mid-90% range and 3-year overall survival at 98 to 99%. So that either of these therapies, people really did very well when they had low-risk, limited-stage disease. So the conclusions of this FLYER trial is that in young patients, a very specific group with non-bulky, limited-stage disease, normal LDH, and good performance status, they can do really well with 6 cycles of R-CHOP or 4 cycles of R-CHOP with 2 additional cycles of rituximab. So they have excellent long-term survival and a low chance of relapse. What it doesn't address is sort of the question of, do we do radiation or not? That's something that we're often talking about in late-stage lymphomas, is what's the benefit of radiation? And classically, in limited-stage lymphoma, we will use radiation as part of that. Currently, the NCCN, this is the National Comprehensive Cancer Network, their recommendations are for R-CHOP 14, so given every 14 days, 4 to 6 cycles with or without radiation. R-CHOP given every 21 cycles, the current recommendations, which were made before this data became available, is 6 cycles plus or minus radiation. So for the R-CHOP 21, they don't have this 4 cycles option in there. But their category 1 recommendation right now is still R-CHOP times 3 plus radiation. So I think that this is something to consider for these very special, very low-risk patients, particularly patients whom you're concerned about the area of their disease that you may not want to radiate them. But one thing to follow up with is that limited stage patients on this study, but even outside of this study, tend to have, most of them are cured, but you can have very late relapses. So sometimes these are patients that once you get out to 8 or 10 years, occasionally will see relapses. So the third randomized controlled trial was for non-germinal center diffuse large B-cell lymphoma, and the background on that is that these activated B-cell or non-germinal center diffuse large B-cell lymphoma patients we expect to do worse than the germinal cell. So the initial data is on the top, which is from this gene expression profiling that was done, and they saw that even in patients who are low risk, patients at high risk, all of them did much worse when they had activated B-cell-like. Then the Hans criteria was developed, which is looking more at staining, more things that we can do in our clinical practice with immunohistochemistry. And when they looked back, they also, this criteria, found that the non-germinal center patients did worse. And so since then, we've always been looking at how can we improve outcomes for these patients with the non-germinal center disease. So this trial looked at ibrutinib in combination with CHOP. And the reason they did that is because we know in these non-germinal center or activated B-cell diffuse large B-cell lymphoma, they have mutations that lead to chronic active B-cell receptor signaling. And ibrutinib is a BTK inhibitor, so that works on that B-cell signaling pathway. And there have been little studies, early phase 2 studies in diffuse large B-cell lymphoma suggesting that in patients with the activated diffuse large B-cell lymphoma, they may have more of a benefit from ibrutinib. So this study was a small study, but as you can see, the patients who got into a CR, that many more patients in this activated B-cell group responded to the ibrutinib with a CR than in the germinal center. So that's sort of the background to this study. This study, pretty large, so over 800 patients, they took patients with non-germinal center B-cell diffuse large B-cell lymphoma, and they were randomized to 6 to 8 cycles of R-CHOP plus placebo or ibrutinib. 6 to 8 cycles was predefined by the treating physician. And what they found was that the ibrutinib plus R-CHOP did not improve event-free survival. In fact, there's a little bit of a trend towards patients doing worse. What was interesting with this study, and something that we frequently see in clinical trials, is that even the patients on the placebo plus R-CHOP did a lot better than we expected historically. So just a reminder, on the right over here, you have these patients with non-germinal center, where only about 35% of those patients are alive 4 or 5 years later. Over here, we're having 70 to 80% of those patients who are alive at 4 years. And this just speaks to how much better patients on clinical trials do, because those patients are healthy enough to get on the clinical trial versus the retrospective data, which may be a little bit more similar to the patients we have. Probably the reason patients did not do as well had to do with toxicity. So if you look at this in the ibrutinib arm, only 80% of those patients were actually able to get the 6 to 8 cycles of R-CHOP, versus in the placebo arm where 90% of those patients were. And this was much more pronounced in the patients who were older. So when you look at these serious adverse events, you see that for the older patients, 67% of those patients on the ibrutinib arm had serious adverse events versus 40% on the placebo arm. And it was more with the younger patients as well, but the younger patients were just able to tolerate it more, so not as many of them had to discontinue therapy. Since this is just abstract form, I don't know whether it was pre-planned to look at the younger patients or not, but they did present data on the younger patients and found that the younger patients, so 65 or less, did have a significant improvement in progression-free survival as well as overall survival, whereas the older patients who are in C and D had actually a trend toward worsening outcomes with the ibrutinib arm. So conclusions for this study were that in patients with non-germinal center diffuse large B-cell lymphoma, first-line ibrutinib plus R-CHOP didn't prolong event-free survival in the intention-to-treat population. It's possible that it could improve outcomes in these younger patients who are better able to tolerate side effects, but a prospective trial is really needed for us to say that. So I don't think that this is something that people are taking this subgroup and now starting to use ibrutinib plus R-CHOP in our younger patients. That's certainly something interesting to think about. And the other thing is that even in the older patients, on either arm, placebo or ibrutinib, patients did much better than we expected for this high-risk diffuse large B-cell lymphoma. So the last trial, I'll just have one or two slides on, and this is a phase 1 or 2 trial for relapsed refractory Hodgkin's lymphoma. So for years and years, all we had was ABVD, and then we kind of went on to ICE or other sort of standard chemotherapy regimens. Over the last 5 or so years, we've had several agents that are FDA approved for relapsed refractory Hodgkin's lymphoma. And now our question is, what do we do with those agents? Do we move them to upfront therapy? Do we combine them? And so this study is one of the early studies looking at combining ipilimumab, which is not FDA approved for Hodgkin's, but is for other agents, nivolumab and brentuximab, both of which are FDA approved for relapsed refractory Hodgkin's, and combined them in a phase 1 or 2 study. So it was small, 22 patients. They had a median of 2 prior therapies. About half of them had a prior stem cell transplant, and only one of them had been exposed to brentuximab vedotin in the past. And what they found was, this is really short follow-ups. This is about a year or 14 months, but really high response rates. So 82% overall response rate and 68% CR rate, which for patients who've gone through transplant and being relatively heavily pretreated was very exciting outcomes. And so there is now sort of a next study. This is a multi-group study going on, which is going to randomize patients with relapsed refractory disease to IPI, Nivo, or brentuximab versus Nivo plus brentuximab alone. And they may have received prior brentuximab as long as they weren't refractory to it. So this should be opening here, hopefully in the next few weeks, actually. Toxicity-wise, even though they were combining all of these different agents, particularly the ipilimumab and the nivolumab, which can both cause autoimmune diseases, people tolerated it pretty well. It was mostly one patient who had a lot of the symptoms of the colitis, gastritis, which are some of the things that we worry about. But overall, it was better tolerated than we might have expected.
All right.
So now, I guess we're going to go on to a few questions.
That would be great.
So which one of these is not an FDA-approved indication for brentuximab vedotin? Previously untreated stage 3-4 classical Hodgkin's lymphoma in combination with doxorubicin, vinblastine, and dacarbazine, which is A. B. Previously untreated systemic ALK-positive anaplastic large cell lymphoma as a single agent. C. As consolidation after autologous stem cell transplant in patients with classic Hodgkin's lymphoma at high risk of relapse. D. Previously untreated CD30 positive peripheral T-cell lymphoma in combination with cyclophosphamide, doxorubicin, and prednisone. And E. Relapsed refractory CD30 positive mycosis fungoides.
Right. And again, these are all completely anonymous, so please just take a moment to go ahead and make your put your answer in either via texting, as we discussed, or via the PollLab website. And take just a few more moments. All right. Dr. Beaven, how are they doing?
So this points out what's hot off the presses, which is that D is FDA approved now.
Okay.
So on the basis of this trial, D is FDA approved.
Okay.
C is also FDA approved. The one that's not FDA approved is B. So this is sort of a trick. Previously untreated systemic alloplasic anaplastic large cell lymphoma as a single agent is not FDA approved, although we often use it in the relapse setting. And now, in combination with cyclophosphamide, doxorubicin, and prednisone, it'll be part of upfront therapy for many patients as well.
Great.
So this one, which of these drugs is not FDA approved for use in relapsed refractory Hodgkin's? Nivolumab A, ipilimumab B, pembrolizumab C, or brentuximab vedotin D?
And again, just take a few seconds to respond to this, if you would, please.
I'm willing to stop there because I like their answer.
You like their answer?
Yep.
All right. It sounds like we're trending.
He's going down. So the answer is ipilimumab. It's sort of FDA approved for other indications, but not this one. So, and then we'll go on to the third question. Which of these regimens is preferred in patients with non-germinal center diffuse large B-cell lymphoma? This might be a little tricky also. So A is just straight up R-CHOP, B, bortezomib plus R-CHOP, C, lenalidomide plus R-CHOP, or D, ibrutinib plus R-CHOP.
Again, we'll go ahead and put in your best guess, and we'll take a few more seconds. Thank you so much to everyone who's participating in the polling. We really appreciate that.
So I think that it'll be very interesting to see as the manuscript comes out and in the coming year what people have to say about the ibrutinib plus R-CHOP in those younger patients who can tolerate it more. But right now, I'd say that for most patients, R-CHOP is still the answer. Lenalidomide plus R-CHOP, there's several randomized control trials that are looking at that right now, but we don't have the answer. And then bortezomib plus R-CHOP, we actually had a randomized control trial which showed that it didn't benefit. So, so I guess we'll move on to you. Thank you, everyone.
All right.
Thank you. And
All right, we'll pass you the...
Yeah.
There you go. And then we'll take questions for both Dr. Beaven and Dr. Moll at the very end. We'll have an opportunity to, that you may share questions with either of them.
And Tim, I need to point out first, I do have a disclosure.
Right.
So I've consulted on one occasion to Janssen,
Right.
to Portola, and to Stargo. So I've been charged to talk about an update in anticoagulation, venous thromboembolism and thrombophilia, the developments over the last year. And we'll talk about cancer and DVT and PE, then VTE in general without cancer, how long to treat, because that's what often hematologists, oncologists in private practice get consulted about. And then an update on the direct oral anticoagulants. And I will let flow into this discussion the key 2018-2019 publications and have a couple of take-home points along the way. So first of all, established venous thromboembolic disease, i.e. DVT-PE in patients who have cancer. How do you best treat them? What anticoagulant to use? The guidelines that exist on the topic are outdated by now because they were developed at the time when the direct oral anticoagulants, i.e. the apixaban, rivaroxaban, edoxaban, and dabigatran were not widely studied. So the guidelines take reference appropriately at that time to using low molecular weight heparin instead of warfarin because it's more effective than warfarin in cancer patients with DVT-PE. So the ASCO guidelines recommend to use low molecular weight heparin rather than the DOACs. The American College of Chest Physicians suggests the low molecular weight heparin over DOAC or warfarin, and the anticoagulation forum also suggests low molecular weight heparin. But this is all at a time where limited data on the DOACs were available. So the developments then are that there are 3 published clinical trials that have looked at various direct oral anticoagulants. They've all compared the DOAC to the dalteparin as a gold standard low molecular weight heparin. Now this is not that widely used in the US. For marketing reasons, the US mostly uses enoxaparin. Dalteparin is much used in Europe, in Canada to some degree. But the best studies comparing low molecular weight heparin to warfarin in the past were with dalteparin. And that's why these studies looking at the DOACs have compared the DOACs to the dalteparin. And the first one that was published a year ago in the New England Journal of Medicine, and many of you are familiar with that, randomized edoxaban, a Japanese direct oral anticoagulant, to dalteparin. It was a large study of more than 1,000 patients with DVT-PE. And the finding of this study were similar to what the other 2 studies that I'll present also showed, that the direct oral anticoagulant was more effective than dalteparin in preventing DVT-PE, more effective, yet led to more major bleeding. So you get a benefit on the less clot side, but you get a downside of more bleed side. So that in general, the average is that they're as good as dalteparin. And that's what the Hokusai trial showed. Edoxaban is FDA approved for DVT-PE use, but it's not widely marketed in the US. It's barely available. I tried to get it on a couple of patients, succeeded with one patient, with the other one I did not succeed. Now the 2 additional trials that came out in the last few months are the SELECT-D trial that evaluated rivaroxaban and the ADAM trial that looked at apixaban in cancer patients compared to dalteparin. Now you will note that both these trials were smaller than the initial edoxaban trial, and particularly the apixaban trial was not all that large. It was really set up to be a exploratory safety trial, not looking at efficacy or non-inferiority, but just to get a feel for, is apixaban safe to use in these cancer patients. There is a larger trial ongoing, and it's nearing the end, that is looking at apixaban compared to dalteparin. The size is very similar to the initial edoxaban trial, and this will finish enrollment by the end of May. Then there's a follow-up of 6 months. I expect that the first data will become available around December of the end of this year, and it may be an ASH presentation at that time. So because you probably are treating patients with cancer who have DVT-PE, I will talk about the 2 trials beyond the edoxaban trial that were just published recently. And this is the one that looks at rivaroxaban, intermediate size, 406. And as I mentioned, the results are the same as what we had in the edoxaban trial. And if you look at the risk of recurrent clots while on the blood thinner, and the yellow is the dalteparin group, and the blue one is the rivaroxaban, there were less clots on rivaroxaban. So rivaroxaban was more effective than the low molecular heparin. But if you look at the major bleed, it's just the opposite, that you have more major bleeds with rivaroxaban and you have than with dalteparin. So that really the net benefit is similar with both drugs. And that's the same as with the edoxaban trial. And then the third trial, the publication is pending, but the data have been presented at the ASH meeting in December, and that's the ADAM trial, and that's the one that I mentioned is just a safety trial, or was set up as that, smallish trial, apixaban versus dalteparin. And what you see is from a safety point of view, the 2 drugs are similar. Apixaban led to 0% major bleeds, dalteparin to cannot quite read it, 2.1%, I think, and that was the same. So this is different to the edoxaban and dalteparin trials, the edoxaban and rivaroxaban trial, that apixaban appears to be as safe as dalteparin. And if you look at the efficacy, even though the numbers are small here, the efficacy of apixaban is better than with dalteparin. So you get 3.4% recurrent clots with apixaban versus 14.1% with dalteparin, which was a clear difference. So it looks like apixaban is as safe as our current gold standard and maybe more effective. So before we move on, there's a question here, and this is maybe a little too early right after the presentation, but be that as it may, the statement about the use of anticoagulants in the treatment of cancer-associated DVT or PE, which statement is true? A, apixaban is as effective as dalteparin in preventing clots. B, rivaroxaban is as effective as dalteparin in preventing clots. C, apixaban has the same risk of bleeding as dalteparin. D, rivaroxaban has the same risk of bleeding as dalteparin, or all of the above.
All right, and again, thank you so much for taking a moment to respond to this poll. And it looks like we're getting a good sampling of responses.
All right. So the correct answer is C. And what I would like to point out as a summary is that apixaban and rivaroxaban appear to be more effective than dalteparin. But from a bleeding point of view, indeed, C is correct. Apixaban had the same risk of bleeding as dalteparin. Rivaroxaban had more bleeding than dalteparin. All right, thank you for answering that. So my take-home point about the management of cancer with established VTE is this. It's reasonable to use edoxaban. That's evidence-based, great study, big study, New England Journal quality. Then it looks like it's okay to use apixaban or rivaroxaban, but the data are smaller, and the big apixaban trial is still ongoing and will come out. So I think for clinical practice at this point, it's reasonable to use one of the direct oral anticoagulants, particularly the ones that we have available in the US, which is mostly apixaban and rivaroxaban, but edoxaban would really be the best evidence-based management. All right, a different topic then is the prevention of blood clots in ambulatory patients with cancer. So both patients that you see with lymphoma in clinic, they're not hospitalized, they're at risk for blood clots because they have cancer. Should some of these patients be treated with anticoagulants to prevent a clot? That's a newish development. Most oncologists think about DVT prophylaxis in some multiple myeloma patients, maybe the pancreatic cancer patients who are at high risk for DVT-PE, but often outpatient prophylaxis is not considered in most other patients. So what are the data on that? There have been two really good studies, the AVERT trial and the Cassini trial, that look both at a very similar population, ambulatory cancer patients who have not had a clot, but at increased risk. Both these studies were just published this week or last week in the New England Journal of Medicine, so we have the peer-reviewed data on that. So the AVERT trial looked at apixaban versus placebo in these outpatient cancer patients. And the way the authors in this and the other trial defined higher risk for DVT and PE patients was by the Khorana score, which is an established score to determine what is the patient's risk for DVT-PE. Now I have to admit or mention, people don't seem to be using the Khorana score in clinical practice. There's been a number of publications. It's a solid score, but whenever I talk to practicing oncologists, they typically don't use that. But what people do think about is, does a certain cancer type predict a higher risk for clots? And what we know is that pancreatic, gastric, and brain cancers do increase risk for clots significantly. The intermediate risk for DVT-PE cancers are lung, lymphoma, gynecological cancers, bladder, and testicular. And then there's a variety of other cancers that are not particularly prothrombotic. So by the Khorana score, you get bad points. If there's a high-risk cancer, you get 2 points. For the intermediate, 1, and the others get 0 points. Hemoglobin, if you're anemic, or if the patient is anemic prior to chemotherapy, that predicts a higher risk for DVT-PE, so the patient gets 1 bad point. A high WBC before chemotherapy is predictive of a higher risk for clots, gets 1 point. High platelet count, prothrombotic, 1 bad point. And obesity with a body mass index above 35, 1 bad point. And in this and the other trial, patients with 2 or more points on the Khorana score were enrolled into the trial. So they had an intermediate or even a higher risk for future DVT-PE. And just to show you, if you really only looked at the cancer types, 25% of them, of the enrolled patients, had a high-risk cancer, not even looking at the other Khorana criteria. And this would be brain, gastrointestinal, or the brain, brain, stomach, or pancreatic cancer. And what the findings of this study were is, not really to a surprise, that the anticoagulant decreases the risk for future clots. And if you look at the development of overall venous thromboembolism, DVT-PE together, in the apixaban group, 4.2% had a VTE, in the placebo group, 10.2%, and this was clearly statistically significantly different. So benefit of apixaban. If we look at the number needed to treat, you have to treat 17 patients to avoid 1 DVT or PE. And that's not that many patients to treat. So that's interesting. What damage gets done? And this is looking at major bleed, and there was more major bleeding with apixaban. 3.5% of people had major bleed versus 1.8% on placebo. Statistically significantly different. So you do harm. And the number needed to harm is 59. So if we were to treat 59 patients with apixaban at this prophylactic dose, 2.5 milligram twice daily, you would cause 1 major bleed if you treated 59 patients. So if you look at the 17 versus 59, that would suggest that there's a benefit of treating patients by preventing clots and not causing too many bleeds. And that's the take-home point from this New England Journal paper. There's a higher, in the higher risk outpatient patients with cancer, it's reasonable to offer apixaban 2.5 milligram BID. And that's a change in how often oncologists think about cancer outpatient management, and is something that should be discussed and should be weighed in the practices. How do we incorporate this into what we do? Now, the Cassini trial is the second trial that looked at prophylaxis, and that's rivaroxaban at 10 milligram QD, the prophylactic dose, versus placebo. Very similar patient population, Corona score 2 or more, and it's a good, well-designed trial, and it's published in the New England Journal. And even though the graph is small here, I'll mention in words what it shows. I must say, I can barely read it.
Check on the left or right screen. That
It's a little out of focus here in the middle, so I apologize about that. So these are two graphs, the way the New England Journal does that, and just focus on the middle one here. This is the risk of a first event of VTE, and it's pretty much the same in the placebo versus the rivaroxaban group. So if you look at the intention to treat group, there is no statistically significant benefit of rivaroxaban. But noteworthy is that 50% of the patients in the trial stopped the study drug, either the placebo or the rivaroxaban, and that's a high number of patients. So then the question comes up, if you really took the drug, the rivaroxaban, how did people perform and how did it prevent clots? And indeed, then you see a statistically significant difference. You have more clots on placebo, you have less on rivaroxaban. The numbers here are roughly 10% versus 6 or 7%, and that's statistically significantly different. So there is a benefit if you take the rivaroxaban. And this is a table that shows the same data, and it's in your handout, and you can look at that. It's the symptomatic events of the VTE, or excuse me, all VTE events here first, and that's a statistically significant risk reduction from 6.4% occurrences to 2.6% with rivaroxaban. And there are also some prevention of symptomatic and as well as asymptomatic DVTPs. Now, does this come at the cost of increased bleeding? Interestingly, no. In the apixaban study, it did increase the risk for major bleeding. Here, it did not. So if you look at major bleeding, placebo 1%, rivaroxaban 2%, numerically different, but if you look at it overall, statistically not significantly different. So the conclusion of this trial for me is, well, I've highlighted this too, this is all bleeds together, the non-major but clinically relevant and major bleeds. If you look at all together, no increased risk for bleeding with rivaroxaban by statistical analysis. So my take-home point from this study is, in the patients who have a higher risk for DVTPE, who are ambulatory outpatient cancer patients, and I haven't addressed the screening here, which we'll get to in a second, but if you treat with rivaroxaban with 10 milligrams, it's beneficial if the patient indeed takes it. Now this point is interesting, and I'll be eventually interested to hear what the clinicians think about that. In this study, before study enrollment, the investigators screened every patient for asymptomatic or minimally symptomatic DVT and did not enroll them. So of your outpatients that you see, 5% have an asymptomatic DVT, which in this study led to the investigators not enrolling the patients but giving full dose anticoagulation routinely. So I think that's pretty high, that 1 in 20 outpatients already have a DVT that we typically would treat, which raises the question whether in the future, should one screen outpatient cancer patients, at least the higher risk people, with a screening DVTP study to then offer anticoagulation? That was not the purpose of this study, but is a question that can be asked. So, together with a junior individual, a fellow at the University of Alabama, Dr. May, we've developed an algorithm how one could think in clinical practice who to offer apixaban or rivaroxaban to. And one starts off, as the clinician does, what kind of cancer does the patient have? If it's a higher risk cancer patient, then the patient already has 2 points on the Corona scale, and then one would evaluate the patient for any exclusion to give anticoagulation, the criteria that were used in the study: low platelet count, coagulopathy, history of major bleeding, renal impairment, etc. And if none of those exclusion criteria apply, then one could offer the patient either apixaban 2.5 BID or rivaroxaban 10 QD, because they were shown to have benefit in these two studies. If it's one of the other cancer types, you get 1 bad point here and 0 points here, then you need additional criteria from the Corona score, the anemia, the high WBC or high platelet count. And if you have then 2 points at least, then again you apply the exclusion criteria, and if the patient is eligible, then you can offer in clinical practice anticoagulation prophylaxis. I think it should be discussed in every healthcare system with practicing physicians. How does this really influence our management at the moment? It's a good discussion opener. So then 3 slides on the topic that many oncologists see, because we're typically hematologist oncologists, which is a DVT-PE patient who does not have cancer. How long to treat with anticoagulation? It's a common question. And I've summarized all the data into one slide with a recurrence triangle. Typically, we would treat a patient with DVT-PE for at least 3 months with anticoagulation. And at 3 months, the decision will be made, should we stop or should we continue? And you would stop if the risk of recurrence is low, and that's the individual in the green zone. Green is good. Tight peak of the triangle means low risk for future clots, 3 months. That's a patient with a VTE due to major transient risk factor, hip or knee replacement surgery. And then down here you would have a red zone, high risk for recurrence if not on anticoagulation, unprovoked clots in men or women. All recommendations are treat long-term with anticoagulation if the patient tolerates the anticoagulants well. And then you have individuals in between. They have some risk for recurrence, intermediate, and we don't quite know what to do, short-term, long-term. And it's those people where a D-dimer would be helpful. A negative D-dimer pushes the patient up in the triangle to the lower risk for recurrence. Positive D-dimer predicts a higher risk for recurrence. And that's a D-dimer on anticoagulation first. And if the D-dimer is negative, we stop anticoagulants, repeat the D-dimer 4 weeks later. And if it's still negative, the patient's in the tip of the triangle, and we continue without anticoagulants. But if the D-dimer is positive or after 4 weeks turns positive, we continue or restart anticoagulation. It is also this group where we don't quite know what to do, where I would think about a thrombophilia workup to find a strong thrombophilia, not the heterozygous Pfeiffer Leiden or not the heterozygous prothrombin, but we're talking about homozygous state or double heterozygous or protein C, protein S, antithrombin deficiency. And if there's a strong thrombophilia in those individuals that pushes the patient down in the triangle, we would argue for longer-term anticoagulation. We weigh against it how much the patient minds being on anticoagulants, the warfarin hate factor or the rivaroxaban or apixaban hate factor, because patient preference is important. We weigh against it the risk for bleeding and then come to a decision. The American Society of Hematology, ASH, will be coming out this year with a very detailed evidence-based guideline on management of DVT-PE. And they've been out for public comments in January. I've seen them. There are no surprises. My summary will still remain this triangle is a helpful clinical tool, short of reading the whole 150 pages of this evidence-based guideline of ASH. So my take-home points from this topic is, as a clinician, you may want to try the recurrence triangle to see how it works with your patient. I find it helpful. We know that the D-dimer predicts recurrence, negative pushes the patient up, positive down in the triangle, and the strong anti-phospholipid antibodies push the patient down if present, and would be one of the arguments for long-term anticoagulation. And then the final and third topic, and I'll go through that quickly, given that we have 5 more minutes, but this is probably relevant for many of us. The development in 2018 on the 5 direct oral anticoagulants that are FDA approved. And they're FDA approved for different indications, AFib, these 4 right here, Betrixaban, not used much, only FDA approved for DVT prophylaxis in medically sick patients. And that's was meant to, it's this one right here. Now, the development last year is that andexanet, the reversal agent, was FDA approved. It's available now in emergency rooms, so that's an IV drug. If major bleeding occurs on one of the anti-10A drugs, andexanet can be considered expensive, $50,000 a treatment, not widely available at this point, but it's FDA approved and the bigger institutions have it, which is good. Idarucizumab is the reversal agent IV for dabigatran, has been available and FDA approved for the last 2 or 3 years. And then the use of DOACs in special populations, and these are patients that we all see in clinic, and I wanted to say a few words about severe obesity. That is a body mass index above 40 or weight above 120 kilos. The data on the use of DOACs in these people is limited because there were not that many in the clinical trials. Additional data are coming out on this topic, but as of 2016, this is the guideline from the International Society for Thrombosis Hemostasis. Because of limited data on the DOAC use in very heavy people, the suggestion has been not to use the DOACs in these people, but rather use warfarin, which we can monitor, and I agree with that, even with the data at the moment. However, if a DOAC is used in these very heavy people, then we need to make sure that the DOAC is roughly in the expected range. And it would be appropriate, the ISTH recommended a peak and trough level. With the additional data since 2016, I feel comfortable saying get a trough level only, just before the next dose is due. And if this level falls into expected range, I'm okay using a DOAC in the very heavy people. These levels are not widely available, but it's a send-out test to the referral labs and can be obtained as a apixaban level or rivaroxaban level. Bariatric surgery, important to know that all anticoagulants are absorbed in the proximal part of the intestine, either the distal stomach, the duodenum, or the proximal jejunum. So any bariatric surgery, banding, Roux-en-Y surgery, changes the absorption area, changes the food transit time, changes the acidity, and you don't know what the patient really absorbs if a DOAC is given. So I would not give a DOAC in a patient with bariatric surgery. I would use warfarin, which can be difficult because of absorption issues, but at least you can monitor it and you know by INR whether the patient absorbs sufficient amounts or not. With the DOACs, you could do a send-out test, but things change over time after bariatric surgery, so it would be difficult after bariatric surgery to use DOACs and repeated testing of the levels to see how to dose. I will talk a couple of slides about renal failure. So the package inserts for rivaroxaban in patients with end-stage renal disease on dialysis, and this is for the AFib patients, allows us to use rivaroxaban, but at a dose-reduced dose, not the 20 once daily, but 15. That's data that are limited, but we can do that. So hemodialysis patients, even though rivaroxaban is renally cleared, dose-reduced can be used. In DVT-PE, the FDA says don't use rivaroxaban in patients with a creatinine less than 30, and I think that's a very reasonable suggestion. We shouldn't be using a dose-reduced rivaroxaban in DVT-PE management with a GFR less than 30 on hemodialysis. Apixaban is somewhat similar in DVT and AFib. Well, not similar, I should be careful. In AFib and DVT, you can use apixaban without dose adjustment in patients on hemodialysis or with renal impairment. We use the same criteria as in non-hemodialysis patients for dose reduction, which is if you meet 2 out of 3 criteria. The patient is very elderly, and I think it's 70 or 75 and above. The creatinine is 1.5 or more, or the patient is very low body weight, less than 60. If 2 of those 3 criteria are met, we should dose reduce the apixaban. But otherwise, if it's only renal impairment, we can use apixaban at full dose. And then Another issue that hematologists, oncologists in private practice do get exposed to is antiphospholipid syndrome in the use of direct oral anticoagulants. And there was a really impressive trial that came out last year called TRAPS study, which took people who were triple positive for antiphospholipid antibodies, lupus anticoagulant, anticardiolipin, anti-beta-2, randomized into rivaroxaban versus warfarin. And they had clots. After randomization, rivaroxaban had a failure rate that was much higher than warfarin. And it was mostly arterial events, strokes and heart attacks that occurred on rivaroxaban. And they did not occur on warfarin. So in triple positive patients who had the very prothrombotic antiphospholipid patients, it's preferable clearly not to use rivaroxaban or any of the other drugs at this point, but rather warfarin. So with that, our final question is, a 62-year-old man who underwent gastric banding procedure 5 years ago for severe obesity now has an indication for full-dose anticoagulation, whether it's AFib or DVT-PE. Which anticoagulant drug may be the best one to use? A, warfarin, B, apixaban, C, rivaroxaban, D, dabigatran. And nothing is moving, so I think
it's fair to
I
go ahead
achieved
and
the teaching points.
Good.
Thank you very much for listening.
Good. And if you could pass the keyboard
Yes.
back. Thank you so much. We have just a couple of moments for questions. If you have questions for Dr. Moll or Dr. Beaven, let me put up the slide here. There we go. So if you would like to share a question, I know we're running a minute or two over time.
I have a
but
question.
Oh, well, there we go. Great. Thank you.
So in your triangle for how long to do anticoagulation, I would put the cancer patient in the high-risk transient risk factor, like at the top. Is that where you would put them?
So that's a really good question.
They weren't on there. That's
Thanks
what
for
I care
asking
about.
that. So cancer by itself is a high risk for recurrence. So it would be at the base in the red zone. High risk, you think about long-term treatment.
Even if, so in lymphoma, I hope that they go into remission.
So that's
So
the
then it's
key then
gone.
is, so then you ask what other risk factors did the patient have. If the DVT was associated with cancer surgery, that was a transient risk factor, so probably that patient moves up in the triangle now, still has cancer, but the surgery is gone. If the patient was immobile, that's in the red zone, but now is mobile again, moves up. And then you're saying the cancer is in remission, is gone, that moves the patient up into the greenish zone. So the key is a DVTP with cancer, one clot is not like the other. You need to list up all the risk factors, which I know you do, and then see which ones were transient and which ones are still present, and then see where does the patient fit in the triangle. Thanks for asking that.
Great, thank you. And we do have a question from our audience. What's the biggest challenge in diagnosing cutaneous lymphoma?
So the cutaneous T-cell lymphomas, it's a huge challenge diagnosing them, and that's not like our diffuse large B-cell lymphoma. You take out a new node and it's easy. For the cutaneous T-cell lymphomas, a lot of patients will have had been told they had eczema for years or psoriasis. Sometimes they've even had biopsies done during that time, which have not shown cutaneous T-cell lymphoma. And sometimes we go back and look at those old biopsies, and they don't show it, even if a future biopsy does. So one of the biggest challenges is I think that when it's almost an early stage in development, really they don't have the lymphoma yet. So it's almost keeping your mind open to the fact that maybe what's going down the road. But it really can be very challenging. The other thing is that a T-cell gene rearrangement can be positive even in non-T-cell malignancies. There's a certain amount of the population that have a positive T-cell gene rearrangement. So just seeing that doesn't necessarily mean you have cutaneous lymphoma. So this, I think, is really something where you want to send them to their biopsy samples to a good dermatopathologist. We have a great dermatopathologist here at UNC, and we actually meet with dermatopathology and hemopathology to go through a lot of those cases. But obviously there are good pathologists all over. But it's really a huge issue diagnosing it sometimes.
Thank you.
Tim, that's another question, so that's a good one. So how do you manage anticoagulation when you develop thrombocytopenia with chemotherapy?
Mm-hmm.
At what platelet count do I feel uncomfortable using anticoagulants?
Mm-hmm.
So roughly people talk about 50,000 and below, you can dose reduce, but below 20,000, you stop anticoagulation.
Okay.
But I think this is an important question because some people with platelet counts of 30,000 have a high risk for bleeding if they have additional coagulopathy, they have a fungating, ulcerating colon cancer, they have had bleeding before, and others have a low risk for bleeding if they have 30,000 platelets, if there's no preceding other bleeding. So even with the bleeding, you do the same. You list up the different risk factors for bleeding so that it's not 50,000 for everybody, but you look at what are the individual bleeding risk factors.
Great, thank you.
Another question.
And yes, 4 patients with the, here, okay. What's your recommendation for FE malabsorption resulting in anemia? At what point should something other than supplemental F?
So that's a really good question, and Tim, this really reflects it's a completely benign hematology question. I think you should have a session on benign hematology, even though this is oncology. Many of the hemonc physicians and nurse practitioners see benign hematology issues. Now, the answer to this question is typically these patients get followed in the surgical clinic where the bariatric surgery was done, and they classically have protocols how often to test CBCs and ferritin levels. These patients come to the hematology clinic sometimes when iron deficiency develops and people have forgotten that they have malabsorptions, but many of these people do need IV iron because the iron absorption is decreased. And unfortunately, too often we see people after bariatric surgery, they get lost to follow-up or they don't get followed very well. They develop iron deficiency over the next year or two, and people try oral iron rather than realizing, look, we need to give IV iron to these people.
Okay.
These days we have a much lower threshold in hematology in general to use IV iron because oral iron is often not tolerated by other people as well, and IV iron is relatively safe to give these days.
What level of ferritin are you looking at when you would recommend IV iron?
So I'm not a friend of one particular lab value determining what you do clinically. So you would look at the CBC, you would look at the hemoglobin, you look at the MCV and the development, you look at clinical symptoms of ice craving. But in general, the ferritin, anything below 30 makes you think this is suggestive of iron deficiency.
Okay, thank you.
Okay.
All right, well, we should wrap up. Thank you, Dr. Moll. Thank you, Dr. Beaven. It's been a pleasure to have both of you. We really appreciate it. Thank you to our audience. Thank you to the North Carolina General Assembly for their generous support of the University Cancer Research Fund and UNC Lineberger. We also want to thank our team, Mary King, Veneranda Obore, and John Powell, for all the hard work they do to make this and every presentation possible. We have lectures coming up. Since we're going over time, just March 13th and March 27th. We hope you'll join us for both of those. We've got lots of information online. Self-paced courses, there's information on new self-paced courses available. All of that information at unccn.org. So we hope that all of our audience members will visit for lots more information on upcoming lectures, past videos, past courses. All right, and thank you so much.
Thank you, Tim.
Thanks to our audience. Have a great afternoon.